Good evening. I'm Marian Dry, Chair of Class Act HR 73, and it is my honor to welcome you to this Class Act Forum, addressing anxiety and depression in young adults, leveraging what works. I'd now like to turn to introducing our moderator and our panelists. Before retiring in 2021, our classmate, Dr. Deborah Wynn, was the acting director of the Division of Cancer Prevention and former deputy director of the Division of Cancer Control and Population Science at the National Cancer Institute, where she continues to work as a special volunteer. Dr. Eugene Beresin is professor of psychiatry at Harvard Medical School and executive director of the new Clay Center for Young Healthy Minds, which provides innovative education about mental health for young people, their parents, and professionals who work with them. He has also just been named the president of the American College of Psychiatry. So congratulations to Gene, and thank you. Dr. Mary Lyons Hunter is a clinical psychologist who has focused on treatment in poor and underserved communities and is the unit chief of the behavioral health department at the MGH Chelsea Health Center. Her clinical interests are anxiety, trauma, and major mental illness with adults and children. She's developed care delivery systems to address both clinical needs and social determinants of health. Finally, Dr. Lucy Obu-Wobodo is a clinical psychiatrist and hospital and medical education administrator. She is specialized in equity-focused organizational initiatives, community engagement, and mental health workforce development. She's on the faculty of the University of California, San Francisco, and has a research faculty appointment at the Massachusetts General Hospital. It's now my great pleasure to welcome my friend and colleague, Dr. Deborah Wynn, to begin the discussion.
Thank you very much, Marian. I'm delighted to be doing this. So, leveraging what works in addressing anxiety and depression in young adults is the topic of this forum. And we have three highly experienced and very thoughtful mental health professionals to address it. In this forum, we will be going beyond what the traditional medical models of treatments for anxiety and depression are to explore what health professionals and systems and organizations, people and communities do now and could do more actively in the future, and how these new models could be leveraged to help more young adults who are experiencing anxiety and depression. I'd like Gene to start us off, and I have a question for you, Gene. So Dr. Beresin, is there an epidemic of anxiety and depression in young adults? And is it true from what we've heard from the news that the whole COVID pandemic experience has been a major driver of anxiety and depression in young adults, or other things involved? And what is it that the healthcare system as it's currently organized can do and can't do in addressing this potential epidemic?
Thank you very much. It's great to be here. I'll try to put it in perspective. Yes, indeed, there is an epidemic of anxiety, depression, and also stress, loneliness, and suicidality among young adults. The evidence for this, and this actually began long before COVID. So, for example, most recently, the CDC released trending factors from 2011 to 2020. And although there was an escalation of depression and anxiety between 2019 and 21, there was a huge increase. So, for example, in girls, feeling sad, hopeless most of the time rose from 30% to 57%. Attempted suicides increased almost double. Anxiety and depression also increased among the LGBTQIA+ community, in which over half seriously considered suicide. Actually, depression and anxiety in these high school students, and comparatively also in the college population, also increased, particularly among youth of color, Latino, African American, Native American, especially Pacific Islanders. Interestingly, the change for Caucasian males wasn't as great. Now, the reason for these changes are hard to determine, but one thing we do know is that this has been a trend that's been going on for a long time. And the overview, I think, is really this. Yes, there are biological factors, but all psychiatric disorders are a combination of bio, psycho, social / environmental factors. So the things that young adults have been worried about, including gun control, climate change, economic downturn, #MeToo. 1 in 5 girls in high school and college students have reported being sexually assaulted. They are worried about society. They are worried about what they're inheriting. They're worried about healthcare disparities. They're concerned about racism and other disparities of people of color. And they're worried about economic prospects. I might also add that storm anxiety has increased threefold. So they're worried about the future. And this was compounded by the COVID pandemic and created, in a sense, a perfect storm. So yes, there is an epidemic, and the Surgeon General reported this, as did the American Academy of Pediatrics and the American Children's Hospital Association and the American Academy of Child and Adolescent Psychiatry. All have noted this as a problem. Among the difficulties for all of these young people is access to care, and for people of color, for very good reason, and I hope this will be addressed tonight, there is good reason for young people of color to distrust the healthcare system and to be concerned about stigma, because stigma is alive and well, and young people are really worried. Even though there's more talk about mental health than ever before, which is the good news, that's the silver lining, there is still a great reluctance to actually try to receive care. And when folks do, there's often a huge waiting list because of the shortage in healthcare professionals. So it's really, in my view, a perfect storm.
Could you maybe talk a little bit more about where the limits of the healthcare system are? And I know that talk therapy and medications are a very important part of addressing therapies, but where is that enough?
No. First of all, talk therapies of various kinds, whether it's cognitive behavioral therapy, dialectical behavior therapy, interpersonal psychotherapy, they're all effective and in combination. And it turns out that medications plus talk therapies summate. So in other words, it's better to have both. But we can't forget the impact of the environment. We can't discount the fact that that there's wariness about the healthcare system. The workforce shortage is huge. So, for example, there are only 8,000 child and adolescent psychiatrists in the entire United States. There are about 4,000 child psychologists, and there are approximately 100,000 clinical social workers. So that's maybe 113,000 clinicians for probably about 20 million young people who are seeking help. The workforce is incredibly low. So when you combine hopelessness, fear of stigma, cultural barriers, healthcare disparities, and a low workforce, you get a perfect storm, not just of anxiety and depression, and of techniques that work. Actually, when an individual is in treatment, long term in general, when I say long term, more than 2 to 12 visits, there's about a 66% recovery rate for clinical depression, and probably about an 80% recovery rate for anxiety. But the problem is getting the young people to receive the help, and also support from the community. Mary can speak to this very well. I mean, the community structures that support mental health engagement work the best. So when we have folks in school and we have all of the caregivers, teachers, clergy, coaches, law enforcement officers, mental health professionals, mentors, you name it, all involved in this mission, and they're all speaking the same language and they all are working together, we've got the best chance of it. The problem is that the society is to a large extent fragmented, and it's really going to take an effort of organization and action to kind of help folks join forces and work together. When young people have a mission, they improve. When they contribute to society or to a mission that they believe in, or to the mental health of their friends, it releases oxytocin in the brain, and that promotes connectedness among people. So, we need to focus on relationships, attachment, and on the whole entire system of care in the community within which our kids live in. I say kids, reservedly, because my college student friends don't like to be called kids. But when folks are all working together, it enhances treatment, it enhances access to care, and we need to come up with innovative solutions for increasing our workforce and our collaboration, both in and out of school, home, community, to actually make a positive effect.
Thank you. Thank you so much for that. That was very helpful, and I really think it helps set the framework for this entire session. So thank you. I'd now like to go on to Dr. Mary Lyons Hunter. So many young adults with anxiety and depression are never treated by psychiatrists and psychologists, and Jean was telling us some of the reasons why that's the case. And they really have no place to turn except to their families, friends, their communities. Now, you've worked on addressing mental health through community-based approaches for many years in Chelsea, Massachusetts, a diverse city just outside of Boston. So what are some of the types of communities and types of approaches that you've worked on that have helped to address anxiety and depression in young adults and address some of the issues and problems that Jean was talking about?
Thank you, Debbie. I'd like to think about, we're talking about young adults, but young adults started out as young children. And these young adults, if we don't treat them, then become middle-aged adults that are now raising younger children that are still depressed. So I like to think about it slightly broader. And that, when we're treating sort of almost any age group, we're treating the family and supporting the family, and that translates into young adults in particular as well. One of the things that I think is notable that, and I appreciate Dr. Boresin mentioning the environment, because the reality is, and I've said this for years, Dr. Boresin knows this, I can't treat someone's depression if they can't be fed. I can't treat their anxiety if they don't know how they're going to make rent. So we cannot disentangle mental health, mental wellness from social determinants of health. They live in the same petri dish. And, all of my tricks as a psychologist fall on deaf ears if somebody's worried about, is mom going to be able to, are we going to be homeless? Or, do we have enough diapers for the new baby that's just arrived? I can't impress enough how important it is that we have to look in a much broader scope. Chelsea was one of the hardest hit communities for anyone in this area. They knew it was all over the news in terms of COVID. And one of the things that we did experience was the power of the community during a very, very trying time. We had one of the highest rates of COVID contraction per capita of almost anywhere except for Navajo Nation in the United States. And one of the things that happened was truly immediately, the city convened a mental health task force. So it involved people like myself, other care delivery systems within the community, but as well as grassroots organizations that were addressing the social determinants of health. Because again, we can't disentangle that. And we met every day. There were about 20 of us in the community that met every day. What do we need? What do we have to do? And I think that, we don't have to meet every day, but some of these same education, some of the same things that we've done, I think continue to be important, because the crisis might not be the COVID pandemic that we're all, that we were all a part of, but there are pandemics that are still happening in these underserved communities, such as housing issues, such as food insecurity. So all of these things are still happening, and I think we need to keep talking about it, not just under the valence of COVID. So this emergency, mental health emergency team, we did quite a lot of, we had a lot of activities that we were participated in, resource sharing, who's got this, who needs this. I just talked to a family, they're in need of this. The schools need this. So there was a lot of resource sharing. There was a lot of education. We did our staff at MGH, as well as other places, other pockets in the community, many Facebook Lives on educating, what to be afraid of, what not to be afraid of. How do you talk to your kids? How do you talk to your teens? How do you manage social media during this time with your teens? How can families construct themselves? How do you get a kid on Zoom to go to school? And also wellness, some wellness and stress management, anxiety reduction kinds of videos. So we were putting them on YouTube. We were putting it on the city's Facebook Live. And that involved both the mental health department and pediatrics. Also, we worked on logistics. I mean, I think our health center alone donated through all of the employees over 15,000 diapers, because if in case people don't know, your food stamp, the EBT card does not work for diapers. So if you can't work and you have a new baby and you have an EBT card, you don't have diapers. Now we have a public health issue. So again, we can't disentangle. One of the projects that I was one of the architects of that was really, really exciting was we identified pretty quickly sort of the disparity around digital access. And yeah, I'm not going to go on about that. I think everyone's heard about that or read about it. But there's no question that the pandemic laid bare the disparity in terms of access to Wi-Fi and other digital access issues. So one of the things that we did was we got some tablets donated. And we said, that's great. We can do our patient visits because we have these, hundreds of tablets that have been delivered. So we construct this program about distribution and all of that, and then realize, wait a minute, people don't have Wi-Fi. Wait a minute, people don't know how to use this. People don't know how to access or set up their patient gateway, the portal to your healthcare. So what we did, which was really exciting, is we enlisted high school students to do this and help us be basically the tech gurus for all of the people in the community, some seniors, some middle-aged, that didn't know how to set up into the patient gateway. So we utilized our teens to do that. They felt fantastic. They felt like they were, again, purposeful, as Jean mentioned. They felt like they had a role. They felt like they were doing something to help. And I think for all of us, those are qualities that we all strive to do and strive to have in our lives. And that was a really amazing program. We also did a very similar program, but not with technology, but around really intense support for pregnant women and newly prenatal, in terms of prenatal care and working with moms so that we could stave off postpartum depression. Jean referenced the importance of the community, and one of the things that I would have to say is, although Chelsea has many, many needs, it also has somewhat of an embarrassment of riches, and that there are many resources that are of like mind. And there's been an ongoing effort for many years to be a trauma-informed community. Part of what we have done in Chelsea is for 25 years, we had a PACT program, which was a police action counseling team. So for families involved with domestic violence, and that involved young children, young adults, teens, we had a social worker that actually rode with the police and would go out after the de-escalation and be able to do immediate interventions with families. So everyone's thinks, oh, that's great, we help the kids. We didn't just help the kids, we helped the community, because on those ride-alongs, that social worker is talking to that police officer, saying, this is what happens to kids when this happens. This is what happens to families when these events happen. If we don't do something, this is what happens. And over time, we were able to create such an incredibly strong relationship with the Chelsea Police Department that I know if I have to call them today and have a concern about a particular family and exposure to domestic violence, I know they're going to treat that situation, that family, with a level of trauma-informed policing that is not available in most communities. So, and we are a community of color. Most communities of color are not going to call the police, and we don't have to talk about the reasons why. Additionally, we have a group that meets weekly to identify any at-risk family. So it might be someone with serious mental illness that has gone off their meds and is, wandering around the community. And this is also a weekly meeting of like-minded community leaders and of various factions from the housing department, from DCF, from DDS, from DMH, from Mass General, from other, community organizations that come together and say, okay, how can we help this at-risk family? How can we intervene this kid is on the edge of joining a gang. What can we do?
Thank you so much for that. I'd like to have Dr. Lucy Obu-Wobodo talk now. So I'd like to ask you a little bit about what how you got into thinking about mental health issues in young people in minority populations. Also, I'd like you to talk about people in disadvantaged communities face enormous problems as they try and access the medical care system and the services that might be there. They just can't find a way in or are not really supported when they get there. Can you talk about some of those issues and how they can be addressed and some potential successful programs that help address this issue for young adults?
Thank you so much for having me. And it's really a true honor to be with this distinguished panelist. My journey into focusing on mental health issues for young minoritized populations really stems from my identity as a Black woman, as an immigrant. I came to this country when I was 11 years old, and I moved to Oakland, California. And I was around a lot of poverty and destitution. And I saw very early on what are some of those structural issues that my co-panelists have discussed, right? How poverty can play a big role in people's overall health outcome, both mental health and physical health. And that passion was some of the catalysts that drove me to want to look at how we address these issues as a physician, but also as an advocate. And when we talk about what we're looking at in this country, when we talk about the disparities and inequities and different outcomes based on who people are, it really comes down to structural racism. And we talk about racism a lot in recent years since the post-George Floyd murder and sort of the national reckoning around our country's legacy of racism. But I think it's important for us to also define it so we know what we're talking about here. So we talk about racism, we talk about structural racism as a really deeply entrenched system in which public policies, our institutional practices, and our cultural representations and other norms work in various ways to reinforce racial group inequities. So this is a deeply, attached feature of our social, economic, and political systems. And because of that, you see the trickle-down effects in all areas, including in mental health. We know that, as my co-panelists have also talked about, when you can't afford to live, this is going to lead to a different outcome mentally. Young people of color, young people from low-income communities who are faced with destitution and poverty or dealing with issues that will lead to a change in how their mental neurobiological state functions. Racism have been shown in various studies, and this is no longer just about, oh, this is the right thing to do, but racism kills. Racism can actually cause adverse changes in your brain pathways that can lead to negative outcomes like anxiety, depression, psychosis, things that we always think about as having other factors causing it. Racism can actually lead to that. It can lead to post-traumatic stress for people and suicidality. And I think it's also important to look at the way it also reduces people's positive mental health. So your ability to have good self-esteem, right? Your life satisfaction, your ability to control and master your life, your overall positive affect with the world, and your well-being can all be affected because of racism. So for us to tackle the issues that affect young people in this country and around the world, we really have to make sure that we are looking at the ways in which race and white supremacy culture in our healthcare system, in our economic systems, in our political systems have adverse impact in how our young people and adults are living in this country. And you mentioned what are some programs that I want to highlight that are doing a really great job at this. You know, I shared with the panelists when we met earlier about the ACOMA project. This is the brainchild of an esteemed Dr. Alfie Berlin Noble, who created this program to look at how to specifically target youth of color and how to help generate collaborations across different sectors to be culturally responsive to the issues facing young people of color. So it's important that we look at things from a racial equity perspective, right? There's no one size fits all model when we're thinking about interventions. We have to be very, very thoughtful about this. And the colorblind way of doing things, the fact that we think that we can apply different interventions at the same places and have the same outcomes, those are no longer seen as evidence-based. So to be very thoughtful in our work, we have to go to the communities that, like Dr. Lyons Hunter was talking about, talk to them, connect with them, make them the center of our work. They are the true stakeholders in what we're trying to do here. There is no outside external input that can actually be effective if we are not centering our work to those who are trying to serve. And it has to also involve cultural humility. And we have to look at the ways in which we come into places wanting to play savior, wanting to change the world, not always realizing that those people may already know strategies and interventions that could help their communities. So really trying to be thoughtful in how we engage with these communities is so important, because we know historically in the modern era in this country that our healthcare system, much of our systems have done just awful harm, truly awful harm to people. And that leads to mistrust, that leads to their inability to want to engage with us. And it leads to what we know as negative outcome. So we all know that we have clinician, biases when we encounter young people of color. They're less likely to be diagnosed with trauma and PTSD versus their white counterparts, even when experiencing the exact same symptoms. They're more likely to be funneled towards our carceral system, leading to early criminal justice involvement, despite having behavioral manifestations that may have led to treatment if they were white. So we have to look at our own interpersonal and provider level issues, but also our own healthcare and political system and our carceral system, and how they all interface to lead to what we're seeing. And we have to be really thoughtful. And I think it's really important to ensure that we're working with the people that we're trying to serve.
Thank you very, very much for that. Now that we've heard from each one of you, we've got your perspectives. There are some cross-cutting questions that I'd like to ask all of you to weigh in on. And for the first question, I'd like to ask Mary and then ask Lucy and Jean to also comment. You've all mentioned and been quite aware of the fact that there really aren't and won't be in the foreseeable future enough psychiatrists and psychologists or other highly trained professionals. So what can we do to address that or expand the workforce or the people force with other communities or individuals, and how would we make that happen?
There are pockets of research and projects that have taken place and continue to take place that use a community health worker model or a peer model, such as the recovery coach, which has become very prominent in the recovery community, the addiction community, and also peer coaches in the serious mental health community, that being able to increase the access to people that are trained, they're also supervised and supported, is something that would be extremely helpful in addressing some of the need. The problem is it's not a billable service. So the insurance companies don't, and our system is as poorly designed as it is, relies on a fee for service model. So that has been a big barrier to increasing that model of care, which we know works.
Lucy, can you comment on this workforce issue?
I am very, very passionate about workforce development in mental health and in healthcare. We are facing a crisis. This is a time of severe urgency. I think it's important for us to reimagine how we can actually start very, very early in young people's development to expose them to careers in behavioral and mental health care. it's important to go as early as kindergarten, middle, elementary, high school, college years, and look at how we can actually bring in training, apprenticeship models to expose them to psychiatry, counseling, social work, neurobiology, places in which they can see themselves in. You can't be what you can't see. And the earlier we start this, the better. There's an innovative program that's actually a really interesting combination of political public sector work with academic institution based in San Francisco at UCSF. The mayor, London Breed, worked with the UCSF faculty to create a program called Change SF, which stands for Community Health Advanced by Next Generation Efforts in San Francisco. This is a really interesting work-based opportunity whereby young people as early as 13 years old to 24 are embedded across different departments at UCSF and the Department of Public Health, and they're getting a chance to get paid. It's important to pay them, right? And they're getting mentorship and educational access that will hopefully they can leverage to a longer-term career in this work. We have to think about experiences and opportunities like that to start very early. And I want to just quickly talk about residencies because I'm an associate program residency director at UCSF. And we know that many, many areas in this country, both in urban and rural areas, have no residency programs where they can train psychiatry workforce. We have to think about ways in which our government and our organization in psychiatry and mental health can come together. Both the ACGME, who are the people that accredit medical programs, so Accreditation Council for Graduate Medical Education, and AAMC, Association of Medical Education, American Medical Colleges, can think about ways to collaborate to expand access with the federal government funding and perhaps grant and philanthropic efforts to embed residency programs in places whereby people don't have access to care. And we have to, really, join in the telehealth phenomenon that we're experiencing and expand our telepsychiatry, telebehavioral health access. I know that we're ending some of our public health emergency from COVID that allowed this to become more expanded. And I'm really nervous about what this will mean if we go backwards and regress towards less access to telepsychiatry. And then lastly, I want to talk about burnout and retention. We are doing really difficult work. Those of us in the mental health workforce are really struggling with the anguish and the pain that comes with caring for a society that is wrangling with so many challenging factors. And we have to ensure that we're actually pouring resources to make sure that we're not losing workforce that we already have. Moral injury is at a high level. We know that people are struggling with finding purpose, with emotional exhaustion in the work that they're doing. So how do we ensure that we're building our provider resiliency with targeted efforts to make sure that we're not losing people in the workforce, because this will actually exacerbate an already really big problem.
Thank you. That's a really important problem. And I have to admire all of the work that all of you do. I'm an epidemiologist, so most of my work is in front of a computer, and you do wonderful work. So, Jean, would you talk a little bit about react maybe to what Mary was talking about with what the community members can do? And one question is, how do you train them? How do if you're trying to expand the people who can help?
Let me comment on that in a little bit of a roundabout way. And I noticed some of the questions. I'd like to address that too. First of all, I want to address what Lucy is saying, and social emotional learning curricula should be mandated from pre-K, preschoolers through college and beyond. I mean, and if you look at the CASEL, the Collaborative for Academic Social Emotional Learning, that puts more people lose their jobs, more people are unemployed, more people, don't succeed in life because they don't make rational decisions, because they don't have empathic skills, because they don't know how to communicate, because they're not inclusive. We need to kind of begin young, as you were saying, Lucy, and educate our students and college students, in social emotional learning. We can train many people. I have fortunately, I got a gift that funded outreach workers in Chelsea, Revere, and Charlestown. And we take students right out of college and we train them to actually be coaches. You know, one of ours is embedded in Chelsea in the mental health system, in pediatrics in Charlestown, and in the after school youth zone program in Revere. So they are trainable. But there's another thing that I want to focus on. I was a program director, Lucy knows this, for a very long time, for 32 years. And the reason we're limited in this workforce, and the reason we are limited in embodying a lot of these courses, is really economics. We have, and I'm going to wax political here and economic, we have a severe maldistribution of wealth. And we need, I think, if corporations, who's going to pay for all of this? Who's going to pay for it? First of all, we're limited in residency training slots because the government is basing that on Medicare funds, which are severely limited by congressional order. Okay, and the government claims that they don't have enough money to do this, and they don't. But imagine if corporations paid 15 to 20% tax instead of zero tax, and we took those funds and we put them into social programs, we would have a much better go at this. So, you know, one of the things I think we have to do collectively, both mental health professionals and anyone who's interested in increasing the workforce, increasing the health of society, is look at the maldistribution of wealth and how we can redistribute those funds to programs that can actually help society. And I think that needs to be addressed, because we can't just say we need more programs, because I've been saying that since, you know, I started as a program director in 1981, and managed care, which is really mangled care, has limited the number of professionals and limited the funds and the reimbursements for all levels of professionals. Even the trainers of college graduates has been limited. So really, there's an economic issue here that lies right under the surface that I think we have to address to implement any of these social proactive ideas. And unless we look at the economics behind this problem, we're not going to succeed.
Can I just add one quick thing, Debbie?
Absolutely.
To Jean's comment. Lucy, you know, you really were quite eloquent. But what we know is that if your provider looks like you have a better chance of doing better, of recovery, of getting, getting healthier. As someone who has been in Chelsea for 25 years and have made a commitment to try to have my staff match our community, it is a gargantuan Sisyphusian task. And part of it is because there aren't enough people out there for me to hire. We need to, from the economic perspective, not only globally do we have a shortage, but we need to find ways to fund and support by the BIPOC community that want to be able to do this work. And that's through not only funding, but mentorship, mentoring these kids out of high school and middle school so that they they know how they can get to where they want to be. So that's my
and I might add, Mary, and I think Lucy, you would agree, that we have not done, and we're just embarking upon recruiting people of color into the mental health field and into medicine, into the caring professions in general. But the field has failed in terms of equity, diversity, inclusion. And until we start making more of an effort, and I know many programs around the country are doing this, but the recruitment efforts have to be increased.
Right.
I want to just jump in really quickly on that.
You can talk. I'm glad you're going to do that. And I think that's going to be the bridge to our next topic, which would be what you think Congress should be doing, what you think the Surgeon General should be doing, what the universities should be doing. So please go ahead, Lucy.
Yes, as you can tell, this is a very, very, important discussion. One of the things I wanted to piggyback off of is, how do we recruit BIPOC, students and learners to enter the field. And it comes down to money. I think it's so important to look at the fact that there is a huge wealth gap in who gets to be a doctor in this country, who actually gets to have the resources to navigate what is a very tumultuous pathway to becoming a healthcare provider. And we have to do everything in our power to level that playing field, because it is a formidable obstacle. To tell a young kid to be a doctor in this country that is from a poor, Black, indigenous Latinx community, it's like saying them to go to Mars, right? It's just as easy to go to Mars as it is to go become a doctor. It is very expensive. And so we need to look at fiscal policy that can actually create scholarship, stipends, whether it's loan forgiveness or loan repayment, or just making medical school way more affordable, even the testing to go through all this process for all behavioral healthcare workforce, the licensing fees, even getting exposure to apprenticeship and clinical models to actually get your accreditation. That requires money and access. Who's going to allow you to shadow them if you don't know anyone? Who's going to allow you to come to the hospital if you don't know anyone? How are you going to pay for a $2,000 test if you are bordering on homelessness? Like, there are so many things we have to talk about when it comes to actually recruiting people, but it comes down to fiscal economic policies, because it is a huge, huge factor in limiting who we have in the healthcare system.
So what should we be telling the universities, and what should we be telling Congress?
Well, look, NYU, one of our MGH graduates, Andy Brotman, who became a chancellor at NYU, made medical school free. How'd he do it? He redistributed the funds. And now, if the class needs to be expanded, but if a place like NYU can fund medical students, and Jess Shatkin, who is the vice chair of education, has an undergraduate major in child mental health. I mean, there are innovative things that can be done, but I think Lucy's absolutely spot on. It's what I was saying before about the maldistribution of wealth and redistribution of funding. That has to be addressed in order to increase slots, increase recruitment, and make these programs affordable and actually actionable.
Recently, I was having a conversation with a recent grad, and they had $500,000 in loans. $500,000.
Yeah.
I mean, that's, how do you wrap your head around that? I mean, that's just unreasonable. But, at the same time, we all want the best healthcare we can get for ourselves and our families. We want the best, we want all of that, but we have to reconcile that with what the cost of it is on so many different levels, as my colleagues have mentioned.
Mm-hmm.
Yep.
Lucy.
I think, one of the things that I think about a lot in my work is prevention versus trying to react when things are already bad. When we think about the mental health of young people in this country, we need to really shift towards prevention in mental health versus what we're doing now, which is a lot of it is reacting to already poor mental health. Yeah. How do we promote mental wellness in young people? How do we promote this in our communities? And I think it comes down to looking at the factors that actually can make someone's quality of life better, right? Having access to nutritious, healthy food. We know that these food deserts and chronic food insecurity leads to negative health outcome. We know that we need to have better housing policy so that we have people not struggling to figure out where they're going to live. We need to be able to increase low-wage workers, with their salaries so they can support their family. Young people exposed to poor, low-income, homes, they end up suffering. So when we talk about policies, we have to really engage all different leaders across all different sectors, both in our government, in our private sector, in our academics, to think creatively and innovatively. How are we addressing all these domains? Some of the recent data coming out of, for example, the recent child tax credits and universal basic income pilots all over the country that's kind of popping up has shown that there's actually improved mental and physical health outcomes for these children who were in these families that got money, right? So we know that there are ways that we can try to address this because we don't want to get to where we are now. We want to go back, and how do we actually fix and help our communities so we're not where we are in this crisis urgency mode. So looking at policies to help us address these factors is going to be really crucial.
Do you think we could do a better job of advertising the success of some of these programs and how that relates to better physical and mental health outcomes?
Someone put in the chat about scale. We need to scale them up, right? Marketing is important, but we need to scale them, and that requires investment and it requires an infrastructure to replicate and study and do research to show the evidence that we are seeing in these places. So it's important to really, yes, like we have to get people to know what's out there, but these are really small, sometimes siloed interventions, but we have to go exponential in our impact to really get to a better outcome.
And Lucy, I'm going to add to, these programs around the country, but there are other first world countries that, look at childcare, look at early intervention that have phenomenal models. And, granted, every country is different, but the impact of having a safe place for your child so the parents can work and have that be subsidized and have it not be just, the have and the have not, or a fairness issue that it all gets bandied about. But yes, we do need to start early, and maybe they won't need us.
Yeah, I also would like to make a further pitch for research as well. I'm an epidemiologist, and so I firmly believes in the need for good information and good data to make decisions about program and expanding programs. And there's not only are a lot of these programs, we're able to study them and look at specifically at health outcomes and be able to say that we have good data that shows better outcomes in circumstances. But there's also implementation science, which is an area of research where you can say, okay, we've shown that this intervention, this program, this educational thing, or this peer counseling actually works in our clinical studies. And implementation science is a way of doing research that scales things up and looks at the effectiveness of these research efforts, and can you make them reproducible? Can you make it so that they're cheap? Can you make it so that you can train people to do it and adapt to new circumstances? So these are doable and can identify effective programs that deserve to be ramped up because they do work.
I'm certainly a big fan of evidence-based outcome measures, but unfortunately, I've had long battles with the insurance industry, and frankly, like Rupert Murdoch, they're turning to the green. They look for the money side of things. They don't, even with the greatest evidence, and we've done a number of evidentiary of outcome-based measures of, looking at reducing homelessness, looking at substance use and disorder treatment, looking at sex trafficking, looking at domestic violence. And we kind of, despite all of the research, and I agree with you, we do need more. We do need much more. We need metrics on everything that we do to demonstrate that it works. Okay. But that being said, there are many forces, including the insurance industry and the pharma industry and other very powerful forces, that it doesn't matter to them. It doesn't matter to them. So there's a disparity between the forces that generate the income to pay for recruitment, to pay for new programs, to pay for good outcomes, to pay for good treatments, and the payors who are much, much, much more restrictive and don't follow the data. And so, I mean, I was having a discussion the other day with Mark Vonnegut, who's a pediatrician in Quincy. And he was saying just what you said. He said, we need more data. We need to know what works. And we need to argue and fight for what works. And I said, tell it to managed care. Tell it to the insurance industry. Tell it to the pharma companies. They what they want, they don't necessarily want that doesn't matter to them. So what matters to them, though, I think, is grassroots movements and organization. And I think that we need to be organized in various community groups and local groups, as well as regional and national groups, to really fight for redistribution and proper use of funding. And, just in that line, access to care. For example, right now, we're not allowed to either see people or write prescriptions outside of Massachusetts through Mass General Brigham. I have kids that I've seen since they were in elementary school, who then go to college, who then go to graduate school, who go leave the state. They don't have a provider. I cannot continue to see them. I cannot prescribe for them. Why? Because the Federation of State Licensing Boards wants everybody to have a license. And what they've argued, although it's not based on case law, it's not based on any laws, it's based on risk and worries about liability, that the locus of care is where the patient is residing at that moment. So if one of my kids is now in, and I'll list 3, Cleveland, New Orleans, St. Louis, and I've been seeing them for years, and I know them and their family, and I've helped keep them stable, I cannot see them without getting licenses in those states. And that's because the Federations of State Licensing Boards makes it very difficult. Now I can pay for it, but you see, this is really about money, narcissism, and power, and what they want. Because it's not as though Prozac is different in Montana than it is in Massachusetts. And in fact, if you look at their continuing medical education credits, they're not different. Their forms are not different. There's no reason. If you work for the VA or you work for the Indian Health Service, you can practice anywhere in the country, right? But if you are a practitioner in Chelsea, you can't practice in Rhode Island. You can't practice in the next state if somebody has to move, for one reason or another. And there's something wrong with that system, and that has to be changed, I think.
Thank you. So I think we're going to wrap up this part of the program, but I'd like to give you each another, Lucy and Mary, to say something further on this topic, and then from that point we're going to go into some of the Q&As, and we'll be starting that in about 2 or 3 minutes. So would you let's Lucy and then Mary.
I appreciate this discussion so much, and thank you, Jean, for bringing up the out-of-state licensure restrictions. I think that's actually an innovation towards trying to improve our workforce, right? If we minimize the barriers, when people can actually see people, we can reach those in rural and isolated regions of the country that don't have access to any psychiatrists, to any mental health providers. And so that's an element that needs to be advocated for. I think we need to do a lot of advocacy at the federal level in parity laws. There's been a lot of, versions of parity that's come through in recent years, but it's still not enough. Many people may have insurance, but their insurance does not cover what they need, right? Having insurance is one thing, but for many people, they don't even have insurance. But like those that actually do, there's long waiting lists, and they don't even get the relevant care that they need. We need to look at mental health as healthcare, and this distinction that's been created by a very structurally imposed system that looks at it differently from physical health has done a lot of harm to our society. This is all integrated, and there's no physical versus mental health. And until our policies with our insurance and healthcare payment systems look at that, we're going to be in this vicious cycle. And I really, at the beginning of my, discussion, I talked about structural racism. It is something that we have to really wrangle with as a nation, as a country, to be able to really make change. It is difficult. It feels yucky. People don't want to talk about it anymore. There are laws in states banning me talking about it. And yet we need to really reflect and do some self-education and look at the different places in our systems whereby we can actually undo what we know, what we're being taught, our practices, our policies that are harming those from racialized communities. And it's something that really we have to face head on with courage, because I can't tell you that we're ever going to really fix the issue facing this country until we address racism head on. We can't avoid it anymore, and we're beyond time to do this.
Well, I think it's mostly all been said. Kudos to my colleagues. But I think, to distill it down is the structures that we are trying to provide care to all of our all of the patients and all of the residents in the United States are broken. And they're going against actually what I think our ultimate goal is towards health. So be it the licensing structure, being the structural racism that exists that keeps people from accessing care. We have a very broken system, and it's very disheartening.
So some of the questions that have come in include how successful have virtual appointments been to successfully interfacing with mental health patients compared to face-to-face? And actually, maybe that gets back to what you were just talking about, whether that's who's allowed to do that virtual appointments, and where the geographic boundaries are. So why don't I ask maybe Jean to take that?
Yeah, I think they've been very effective. I mean, number one, they've been used for years. I mean, at the risk of, of divulging the unspeakable, I've been, when people were out of town, I used a telephone. When I needed to, I used, even though Skype is not HIPAA protected, if a patient knows and I tell them, I get informed consent, and I say, we can talk on Skype because they're, someplace remote where they can only, use Skype, fine. But virtual visits are extremely helpful. As a matter of fact, one of the advantages of virtual visits, it's kind of like the old days when I was at the Chelsea Community Counseling Center as a resident back in 1979, and I used to do home visits, okay? And I do speak a little bit of Yiddish. And I would see these patients in their homes. Doing a virtual visit as a child and adolescent psychiatrist is extraordinarily powerful. Why? Because I get to see the parents, the grandparents, the kids, the dog, the pets. It's like being in the home. And frankly, I would rather do that than see somebody with masks on, halfway across the room, which I don't think is nearly as effective. Now, there are times when I do need to see people in person. If, for example, I have to measure vital signs, or I have to kind of check a blood pressure or something like that, sure. But virtual visits we've been using telemedicine for a very long time. And it actually was part of the Surgeon General's recommendation to embed care in pediatrics, in schools, where the kids are, where in after-school programs, and also using telemedicine. Those were the major recommendations that the Surgeon General, as a pediatrician, made for helping to work with this epidemic. And we're not able to do it.
So Lucy or Mary?
So we are able to do it. And just a little factoid, I've been back hybrid since August, and I have seen a total whopping 5 patients in person because my caseload, and I have a busy caseload. They said, Mary, if I don't have to get a babysitter, I can see you during my lunch hour at work. I can, it just expands the access in a way that I think is powerful. And
The no-show rate.
I was just going to say, our no-show rate dropped from 38% to 50% during 15% during the pandemic.
That's amazing. Wow.
Yeah.
Wow.
But here is one of these structural barriers. If I have a patient that's gone to New Hampshire because they've got a sick, relative, and they're in New Hampshire taking care of them, I cannot see them even virtually because my license doesn't work where they are. Now that makes no sense.
So you do it anyway. That's what I do.
Jean, we're on a very large forum here.
Yes,
I know.
Next time I see you, ask me about my patient in Greece. Just leave it at that.
Okay.
And Lucy, and your
I was going to comment on the no-show rate, which has been, when I was in residency, I was admin chief here at the MGH McLean program, and we were looking at the schedules of residents, and a lot of them had 0, no-shows. Everyone was showing up to appointments, especially at the beginning of the pandemic. It was really powerful because you see that people who wouldn't come before were coming. And especially for those who have psychosocial complexities in their lives, those who are unstably housed, those who are going through difficulties in their day-to-day lives, being able to, quickly get on either a phone call or on a Zoom, that really increases, their quality of life. And I think we need to look at what this pandemic has shown us, right? Like Gene was talking about how he was doing it back in the old days and how he, was configuring it. We need to, scale this, right? People will show if they have access, and we need to reach more and more people. And we need to look at our digital innovation and the Wi-Fi, broadband issues in this country, and figure out how to democratize that access. Because as we're innovating with, telehealth care, we have to also look at the fact that people can even access that too.
Right. And I think another point to what you were saying, Lucy, is that one of the healing factors of in mental health is the relationship between client and clinician. And when that's breached, care drops, health drops. Maintaining continuity of care is really super important, and maintaining the relationship. And this is one of many ways that we can actually do that.
This has been a very good discussion on this topic of telemedicine. That's great. So now that we're going to change wheels here, or change direction here. So among health professionals, is there a perceived difference between mental illness due to physiological causes and mental injury caused by things done to otherwise normal people that causes them to perceive life differently and become hopeless, fearful, anxious to the extent that it impacts life and functioning? Are those different?
Yep.
Do we handle them differently? Should we handle them differently?
First of all, it's a false trichotomy. That's a neologism. It's a false trichotomy that the mind, body, and environment are separate and distinct. I mean, it goes from Cartesian dualism to a trichotomy. What, as Lucy was talking about in terms of PTSD, structurally affects the brain, just as meditation does. I mean, so the mind, body, environment separation is really false, number one. Number two, when you make those connections and you keep those connections in mind, you realize that physiological problems are mental problems, they're just different labels. And frankly, I think it's really a false pretense that they're different. Now, there are critical periods. So 0 to 3 is really critical. And 14 to 26, the young adulthood, that's the time when the lower centers of the brain, the so-called reptilian brain, the amygdala, the hippocampus, the cingulate gyrus, form connections to the higher centers of the brain and eventually come all together at the orbital frontal cortex, right behind my eyeballs. Now, that period of myelinization or of forming, the connections, that's another seminal period of time, 14 to 26. That gives us all a second chance, as it were, to kind of help correct things. So while there is a false trichotomy, we do have critical periods that we have to pay attention to. And that's why I think this forum is so important, because young adulthood is that period of time when we really have an opportunity, as much as 0 to 3, to help young people change.
I think, in terms of what I said earlier, right? We can't separate people's environment and their lives from how their body, both physically and mentally, reacts to things. Behavioral manifestations of trauma, of poverty, of, illness, of exposure to violence, of, a negative policing system, all of these things are integrated in how people experience their lives. So I think that in our education, right, for young learners coming up, we need to, stop doing that, like physical versus mental versus this, because it really does lead to part of the stigma that people experience with mental health. There's almost this idea somehow that it's a moral failing, there's some kind of character flaw involved in how you're experiencing your life. And if you just, work hard enough, you could just not feel sad or not feel anxious. So when we look at things and try to put it as this is just mental health versus, oh, this is actually a physical health issue, we can actually cause patients to experience more stigma and harm. So we have to look at our language that we use and how we teach and how our norms in the clinical settings also can perpetuate those factors.
The only thing that I'll add, and if people want to read a little bit more about this, to me, the Kaiser Permanente study on ACEs is an important one to think about. ACEs meaning adverse childhood experience. And what it shows is the long-term sequelae on health, not just mental health, on physical health, if a child is exposed to an adverse event, be it domestic violence, be it divorce and separation. And they have been able to quantify that. So that's a place to look, take a look if you really want to see the intersectionality of the physical, environmental, and mental health. That study really lays it out, as do many other, but that one is pretty clear.
Thank you. So another question is, could we have a brief discussion of the impact of social media on depression in teenagers? Is it a force for good or not?
Both. And here's why. Digital media, first of all, there's a lot of bad research on the impact of media, for example, on violence. I've done a fair amount of research on that myself. But looking at the pandemic, I mean, one might say that yes, there are detrimental aspects to social media. There are detrimental aspects because of misinformation, because of the fact that parents, for example, and kids don't really are not media literate and need to learn what platforms actually are telling the truth or not. But there are, and during the pandemic, digital media was a godsend, for example, in making connections between peers, when I was FaceTiming my grandchildren every day. We did Spotify playlists together every day. So in certain times of hardship, digital media can be used for very productive means. Now, that being said, it can also, the number one cause of bullying is cyberbullying, and one in three are cyberbullied. So there are real dangers to social media, and I don't think we as mental health professionals or as physicians or caregivers in general and parents know enough about media literacy. And I would suggest that people go to commonsensemedia.org to learn about what their kids are watching. Most parents have no clue about what their kids are watching, and there's no control over it. So there are risks, but there's also benefits, and the research is out there.
Okay, so Mary, 1 minute. Lucy,
Yeah,
1
I would
minute,
just
and
say,
then
it's a real opportunity to educate parents, because parents, their literacy around, social media is so limited, and how to help regulate, how to have discussions. There's a real opportunity for education.
I think the social media is like the cart that's like run away from us, and we're just now trying to catch up to it.
Yeah.
I think one of the things that make young people particularly, intrigued and piqued by social media and connected to it is also part of like their age and where their brain development is, right? We know that there are parts of the brain that, modulate our hormones like oxytocin and dopamine that leads to these need for, admiration and attention from others. And that the ways in which brain development leads young people to sometimes making poor judgment that then live permanently online, right? Back in the day, you could make a mistake and walk away from it and nobody knows. Now there's a permanent record of every, poor judgment you made while you were still in the early parts of your brain development. And that has consequence longitudinally for young people. I think the amazing, benefits of it, for globalization, for connecting us to the world, for learning about other people. And for some of our LGBTQ youth, in rural areas and areas that don't have, a lot of, visible community support, social media has been a place for them to find connectedness. And so we can't minimize that, though there is some correlations in studies have shown that there is increased eating disorder patterns based on what people are seeing on these social medias. There's increased anxiety and bullying. And so it can be this, blessing on one hand, and yet it can also have some toxicity that we have to, modulate. I think as a society, we need to actually keep these data mining social media behemoths, in check, and really try to look at the ethics of what the products they're putting out there is, and having them create, barriers and, protections to help, our young people, because a lot of what they're studying internally with the Facebook study a couple of years ago they're showing and they're monitoring this, and they're showing the negative outcomes of some of their own products. So how do we actually have more transparency and more engagement and more accountability from us as a citizenry to these companies?
Thank you very much. I think it's now time for us to talk about calls for action. Marion, would you like to tell us what a call for action is and get us started?
I would be delighted to tell you what a call for action is. Class Act is an activist organization, and when we give these Zoom forums, we want the listeners and participants to be able to have opportunities to think about how they can work in their communities or more globally to move whatever we're talking about is forward. And so we'd love to call on each of you to give a call to action that you think is important to you and to the work that you do and to your communities. And at the end, Class Act will also have its own call to action.
Okay, so why don't we start with Lucy?
Yes, thank you for this. There are so many calls to action that's already been outlined in this discussion, and I feel so enriched by this talk today. I think my call to action, and it's one that is embedded in all that I do, is making sure that we're actually applying a racial equity lens to mental health advocacy, and that we as providers in healthcare become advocates. There's no neutrality, right? That is actually its own stand. We have to actually put our foot and put our head into the fight, and we have to look at trying to take stand on issues that may not appear to be related to mental health upon first sight, but are, right? Mass incarceration with Black and Brown people being highly disproportionately, represented in those systems, our residential segregation and housing factors. We have to get in that fight, right? Our poverty factors, our food insecurity factors, our climate change. There is no more time to just be a doctor, just be a provider, just be whoever. We all have skin in the game, and we all have to leverage our expertise, our work, and our experiences and our heart to trying to address these issues.
Thank you very much. Appreciate that. Mary.
So I think we've addressed throughout the forum many of the macro issues, such as workforce development and fractured systems, for across the board, but also for communities of color. When I think of my little slice of the world that I have some, a tiny bit of responsibility, feel a responsibility for, I think of, how do we take the best and the brightest in some of these underserved communities, these kids with less opportunities, and how do we help level the playing field for them? How do we give them opportunities, even something simple like sports? Many of them don't have access to sports. I'm sure all of our kids had access to every sport, lacrosse, tiddlywinks, whatever it was. Let's give them an access them that they can do something meaningful after school, that they can be with peers and not on the toxic social media. How do we mentor these kids? These kids, many of them are first generation or immigrants themselves, and the families don't know how to help them get from A to B. How do we help them do that? There are programs, let's scale it up. There are communities that are doing this, let's scale it up. And a lot of these aren't always consistently happening in underserved communities. And let's give these kids jobs. Let's give these kids jobs during the summer that expose them to other kinds of careers. We do that in the health center, but in IT companies, let them see what the world is like. We can do that. This is not that complicated, but the impact is huge.
Yes, thank you. Jean.
Given the Surgeon General's report there were some wonderful things, such as embedded care in pediatrics in schools and community centers, and in use of telemedicine. But one thing that was absent was the need for public mental health education. And when you think about it, many pap smears, mammograms, car seats, secondhand smoke, seat belts, Smokey the Bear, you can prevent forest fires, sunblock saved millions and millions of lives. And they began with public health campaigns and education about driving and about seatbelts and about smoking. How many mental health campaigns have been we've seen? Well, I remember Friends Don't Friends Drive Drunk, but there was just one image. And the other image, everybody remembers it. This is your brain on drugs with the egg in the frying pan. Remember that image? DARE failed. It didn't follow it up. So what I think, and if you ask most people to define generalized anxiety disorder, panic attack, social phobia, depression, they can't do it because they don't have the information. And so I think the more we can educate the public about what constitutes well-being, what constitutes mental health, and what to look for. At the Clay Center, we think about it as 3 W's: what to look for, when to worry, and what to do. If we had greater public mental health education, we could streamline the system. We could have more meaningful conversations between parents, caregivers of all sorts, and clinicians, and with each other. And we could all be on the same page. We would actually help. It would be the cornerstone, I think, or a cornerstone of prevention, of early intervention, and destigmatization. Because once we realize 1 in 4 individuals will have, at any point in time, will have a psychiatric disorder, and during the course of a lifetime, 1 in 2. 1 in 2. It's more common than strep throat, and yet it's so stigmatized and so misunderstood. I think when people realize it and we bring it out of the closet, when I talk in front of an audience, I say, how many people here either have or have a friend that has a psychiatric problem? All the hands go up. All the hands go up. So it affects everybody. And yet we're not doing enough to have a public mental health educational campaign. So that would be my call to action.
Thank you so much. I'll give a quick one from me, and that would be to encourage people to participating in clinicaltrials.gov is a place where anyone can go and look for clinical trials or observational studies that address mental illness and either its prevention or interventions or treatments. And I'm not just talking about medicines or very clinical oriented interventions, but research can include things like what the effects of how you can best use social media to address issues of anxiety and depression in young people, or how community programs can best address these issues as well in effective ways. So research can encompass a lot of different approaches that we've been talking about that can be studied and hopefully found to be effective and then ramped up. I think that will bring the end to my part of the program, because I'm going to turn it over to Marian, because I'd like to hear what she has to say about a call for action.
Well, and thank you. And what an extraordinary conversation. And the Class Act call to action is focused on one of our bridges, and Class Act's action includes what we call bridges, which are ways in which we help nonprofits that are sponsored by our classmates to do their work. And the Cole Resource Center, a bridge partner of Class Act, is sponsored by our classmate Ellen Farron. And I just wanted to tell you a little bit about it. CRC is a nonprofit, small nonprofit in the Boston area, providing peer support for individuals living with mental health conditions and their families. All CRC staff have lived experience with mental health challenges, either their own or those of a family member, and they share their positive outlook and expertise with others. CRC currently offers 3 activities: custom referrals to mental health resources, support groups, and its workforce development program. CRC's workforce program is a unique service that provides both individual coaching and community for job seekers in recovery as they find their next career steps and pursue their life goals. CRC is an independent 501c3 led by our classmate, as I've said, Ellen Farren, and all CRC services are offered free of charge through philanthropic support. CRC's successful impact demonstrates the value of non-clinical support as an important complement to the services of the healthcare system. And so we can suggest 3 ways to support the Cole Resource Center. One is to donate. Another is to volunteer your time. And if you have time and you could help them in roles that include communications, mentoring of workforce participants, or assisting CRC's management team, that would be great. And finally, if this appeals to you, CRC could be replicated in your own community. And if that's something that you would like to discuss, you could reach out to Ellen Farren at the Cole Resource Center, and her email address will be in the chat. So I want to thank you, Debbie, and Lucy, and Mary, and Jean for such an incredible conversation. We've learned so much from you, and there is so much to think about and to do. And thank you for all you're doing in the world. My thanks also go this evening to the members of our program and production teams who have worked hard to put this together and to find our wonderful panelists. And they include Ken Bolliard, Ellen Farren, Claire Wilson, Carol Tobias, Andrea Kirsch, Sarah Greenberg, Jackie Swearingen, Sarah Ulrich, Katie Marinello, Kate Freed, Diana Labanchu, and our videographer, Rick Brotman. Thanks to all, and particularly to our panelists and moderator, and good evening.